All right, welcome. Today we're going to break down the essentials of musculoskeletal trauma, looking at it through the lens of ATLS guidelines. We're going to focus on those critical first few minutes decisions you have to make to save not just a limb, but a life. Let's dive right in.
So, here's our game plan. We're going to walk through this exactly like you would in a real trauma situation. First things first, save the life, then save the limb. After that, we'll get into some of the major complications you've got to watch out for, and we'll wrap up with pain control and immobilization. It's a flow that's built for those high-stress moments.
Okay, let's kick things off with a scenario. Picture this. Your patient has a mangled leg. You can see the bone, and there is a lot of bleeding. In that chaos, what is your absolute number one first priority? Just take a second and think about it.
And the answer is simple, and it's totally non-negotiable. You stop the bleeding. Before you even think about the fracture itself, before the airway, before anything else, you have to get control of that massive hemorrhage. This is the heart of the life over limb principle.
And listen, this isn't just some textbook theory. Look at this number, an 85% drop in deaths from extremity bleeds in the military, just from bringing back the tourniquet. That is staggering. It shows you just how powerful this one simple tool can be. It's a true lifesaver.
So, how do we do it right? It's a quick sequence. First, get eyes on the wound. You've got to see what's bleeding. Then, grab a commercial tourniquet and get it high and tight on the limb. Don't waste precious seconds trying to get it 2 inches above the wound. Just go high, go tight, and crank it down until that bleeding stops completely. And the last step, which is absolutely critical, write down the time.
Okay, so the life-threatening bleed is under control. Your patient is starting to stabilize. Now your focus can shift. The priority becomes saving the limb, and that means you're now hunting for the next set of immediate threats.
And probably the sneakiest, most dangerous of these limb-threatening conditions is compartment syndrome. You've got to have a high index of suspicion for this one. It's where the pressure inside a muscle compartment gets so high that it literally chokes off its own blood supply. You miss this, the patient loses the limb. It's that simple.
Now, we all learn the classic P signs, right? But the one you have to remember, the earliest and most reliable sign, is pain out of proportion to the injury. If that patient is just screaming in agony way more than you'd expect, you have to be thinking compartment syndrome. If you wait until you can't feel a pulse, well, you've waited way too long. That's a very late sign. All right, let's shift gears to open fractures, when the bone is sticking out through the skin. This is a battle on two fronts. You're trying to stabilize the bone, of course, but you're also in a race against the clot to prevent a nasty, deep infection from setting in.
So, what antibiotics do you reach for? Well, it's all guided by how bad the wound is, using the Castillo-Anderson scale. You can see for the less severe type 1 and 2 injuries, a good dose of cefazolin usually does the trick. But for those really nasty type 3 injuries, you need to bring in the big guns, adding something like gentamicin for broader coverage. The key here, no matter the type, is getting those antibiotics on board early.
And please, don't forget about tetanus. Any open fracture is considered a tetanus-prone wound. It's simple. If you don't know their vaccine history or it's incomplete, they get both the vaccine and the tetanus immune globulin. If they're all caught up but it's been more than 5 years, just a booster shot will do. This is a simple thing that prevents a truly terrible disease.
Next up, let's talk about something a little more subtle, a complication you might not see right away. It's called crush syndrome. This is what happens when a big chunk of muscle has been compressed for a long time. The real danger actually starts when you release that pressure, because that's when a flood of toxins gets dumped into the bloodstream.
So what's happening here? Well, the mechanism is called traumatic rhabdomyolysis. Basically, those crushed muscle cells burst open and release all their contents, including a protein called myoglobin. And myoglobin is really toxic to the kidneys. If you're not on top of it, this can spiral into acute kidney failure fast.
So how can you be sure? Besides the classic sign of dark, tea-colored urine, the lab value you need burned into your brain is the creatine kinase, or CK. A level over 10,000, that's your diagnostic marker. If you even suspect a crush injury, get a CK level right away.
Managing this is a real balancing act. Your number one priority is to flood the patient with IV fluids to try and flush out those kidneys. But, and this is a huge but, you have to be careful not to make any ongoing bleeding worse. It's a constant push and pull. At the same time, you're watching the monitor like a hawk for high potassium levels, which can cause deadly heart rhythms.
Okay, let's move on to nerve injuries. Here's a rule to live by. With every single fracture and dislocation, you must do a detailed neurovascular exam. It's not optional. Nerves and bones are right next to each other, so when a bone breaks, the nerve is in the danger zone.
Now there are a few classic combos you just have to know. Anterior shoulder dislocation? You better check the axillary nerve by testing deltoid function. A fracture at the top of the fibula? That puts the common peroneal nerve at risk, which can lead to foot drop. And a posterior hip dislocation can easily squish the sciatic nerve. And remember, always document your exam before and after you do anything to fix the injury. Finally, let's talk about two of the fundamental jobs we have in musculoskeletal trauma: getting the patient's pain under control and making sure the injury is properly immobilized so we don't cause any more damage.
For pain management, the motto is safe and effective. That means using small, repeated IV doses of narcotics until the pain is managed. Now, nerve blocks can be amazing tools, but here's a huge word of caution. If you have any suspicion for compartment syndrome, you avoid a nerve block. Why? Because it can completely mask that key symptom of escalating pain. And of course, always have your reversal agents ready to go.
And for immobilization, just know the basics. A simple sling is perfect for supporting the forearm or stabilizing a shoulder dislocation. But if you need more stability, say for a clavicle fracture or a break high up on the humerus, that's when you add a swath. That extra piece secures the whole arm right to the patient's chest, keeping it from moving around.
Okay, let's boil it all down. What are the absolute must-knows? Number 1, life over limb. Stop the bleed first. Number 2, always be suspicious of compartment syndrome. 3, for open fractures, get antibiotics and tetanus in early. 4, anticipate the chaos of crush syndrome. And 5, perform and document a thorough neurovascular exam every single time.
So I'll leave you with one final question. You've done the hard work up front, the fracture is splinted, the patient's pain is better, things seem stable. But your job isn't done. What's the one thing you absolutely cannot stop looking for? The answer, of course, is compartment syndrome. It's a slow burn, it evolves over time, and your constant vigilance is the only thing that's going to save that limb.